Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Okay, so welcome back to Cools for the second part of our podcast on Glenohumeral Gurus. This podcast is then going to focus on shoulder instability. I've already talked to Anne about some of the burning questions I had around scapula and EMG function and when we should bother and when we shouldn't. So you guys should check out that podcast on the scapula. But this one is to talk then about shoulder instability. Now, I just wanted to say, Anne, you've been such an incredible influence on my work and my way of thinking from across the other side of the world. What do we think about your career as it spanned and you've made such an enormous contribution in the space of shoulder research? What for you, what has the highlights been?
Well, thanks again for inviting me for the second part. It's fun to talk about scapulas, but it's also fun to talk about instability. I think my career is more like ending than it's starting, so I'm not in the middle. But I think one of the highlights that I felt over the 20 years is how I can translate research to the clinic. It's so important when we do research that it's applicable in the clinic. And very often when I teach courses to people who are already working in the large field of physiotherapy, that I say I want to translate research to you. I want to show you that you can use the results of our studies the day after you read a paper or you follow a course. And all my research questions over the years were also always based on the clinic. So you do something, you say, oh, am I doing something right? Am I wrong here? And then I have the privilege to do research, to formulate a research question on that specifically. And sometimes it is when you are, for instance, in a plank position. Oh, should I extend the left or the right leg to have more influence on the shoulder? And sometimes it's the question, how does it work in this specific patient population? But I really like to translate it to the clinic so that people can feel that we do research not to do research, but to help the clinicians help their patients.
Yes, and it really has had such an enormous influence on thousands of clinicians, it must be. So
I hope
yeah.
so. I'm very honored to
Yeah.
be in that position. I really like it.
Yeah, that's wonderful. So we presented and discussed that at a recent shoulder conference in Rome. There were some really interesting discussions that we had on shoulder instability. I was presenting some of my paper, and really the feedback was some of the discussions about what I wanted to talk about shoulder instability and what the similarities are in our approaches and what the differences are, because I think maybe like I'm way over here in New Zealand and you in Europe, but there are similarities in our approaches, and if we knew what the similarities were, then I wouldn't have to be so far on that side and you wouldn't be the other, where we would really truly know what's important, which I guess is it's a Delphi study, isn't it? But what that looks like, I think let's talk about traumatic instability first, because in New Zealand we see lots of that. My approach has been to make sure I'm recruiting rotator cuff independently of other musculature. So I would look to see in your posterior cuff that you are external or loading, and I typically do that with external rotation without the scapula moving, that I would differentiate between, and I think a lot on substitution patterns that you use then, instead of if you were weak in your inner range cuff, that your brain would just give you scapular retraction instead. And so then I pay attention to the posterior cuff and then as a part practice motor learning type model, because then I have inner range strength of the cuff. I think about it, if you don't have all that range, that your humeral head could slide. I'm interested in your thoughts on part practice and whether we should pay attention specifically to the cuff and the scapula separately. I treat them separately and then combine them as we go along. Is that what you do? What are
Yeah.
other?
I think for me, the dislocations are not the most difficult types of instabilities because an accident happened, they have an injury, they have probably some structural damage, and we have to make sure that they are recovering in a
Yes,
reasonable time without having the guarantee that will not dislocate again, as you have proven in your
yes,
papers.
yeah,
So I think that the local focus on the rotator cuff, I only do that in the beginning.
yes,
Even when they are in the sling, I know you also examined whether we should have a sling for 2 days or 6 weeks, and it's somewhere in between because no
yes,
immobilization is also not good. But in the time of the immobilization, I think there is not much that we can do. And that's the time where we have to keep the rotator cuff awake. What I do
mm,
once that they are out of their slings, then I work more on a functional level. I would like to start with some bench slides and wall slides because I really want to, like everyone wants to rehabilitate the function. And I think the local motor control on the scapular level as well as the glenohumeral level is more something that we can do in the sling because there is nothing else that they can do.
yes. But my concern is then we miss some of this outer range work, because
Hmm.
this is where people
Ah, yeah, yes, yes.
So then I would spend time with subscapularis eccentrically loading you out into external rotation, making sure your control. I've got my foot palpating into my armpit now as I feel myself coming back. But and so then I would start below shoulder height, progress above shoulder height, and really pay attention to making sure I had cuff control all the way through that range.
Yeah. Well, I think I will probably do the same kind of exercises going into the range that was considered
Yes,
to be dangerous, but I don't
yes,
think too much about muscles at that moment anymore because it's
right.
just we have to get rid of their fear of the position.
Yes.
And I also think, and it was really interesting when we were in Rome to see that all roads lead to Rome, that you
Yes.
can have different opinions and different approaches for the same patient. So in like you are focusing on the subscapularis, when I
Mm,
do this and I want to make sure that the human head is not moving forward, I will focus on the infraspinatus because it pulls back the human head. So the result is the same. We want to have more posterior position of the human head in the glenoid.
yes.
You feel that you focus on the subscap, and I feel that I focus on the posterior cuff, but the result is the same. And that is, I think, one of the most interesting thoughts that I make from a world conference is
Yeah.
that we all have different approaches, but we have similarities, of course,
Yeah, of course.
but we might have the different approaches and still the patients are happy. So the approach
Yes.
can be different and the result may be the same. So if you say, oh, the subscap is really important for me, uh,
Yes.
to be able to do this movement without any fear of instability, then I will
Yes.
say for the same movement, for me, the external rotators are important. But we do the same exercise.
Yeah. So let's take that through because this is what I want to discuss with you. The patient is supine and I am loading them back. So subscap is working eccentrically. This is my
Yes.
view. And if I train their subscap and I have this belief, and it's just a belief that you get some subscap inhibition in the presence of pain, similar maybe to a VMO type thing. Therefore, you get substitution through to pec major latissimus dorsi. And so your subscap isn't stabilizing your humeral head as you come back there. In that position, in supine, do you think your posterior cuff is really helping? It's not weight bearing? What do you
Yeah.
think?
Yeah, but the posterior cuff, okay, this is really technical now.
Yeah, I know, but that's what I wanted.
Yeah. the posterior cuff in this position is not working into the direction of external rotation because indeed that is with gravity. So you don't
Yes.
need your external rotators. But when you
Okay.
activate them, they pull your human head backwards. So for instance, I have a movie of that, of a patient. He has a bad shoulder, many
Yes.
dislocations, had surgery, was not better. That happens. And he cannot go into external rotation because of the fear of apprehension. But if you
Yes.
give him a small external rotation resistance, he can reach 90-90 because, and that's again my clinical opinion, because
Mm,
you activate the external rotators, it pulls the human head backwards and
yes.
it creates a better kinematic condition in the shoulder. So,
Yes.
but bottom line, I think both of us are correct here because it's all about the balance between both sides and whether you
Yeah.
explain it more like I want to work subscapulocentrically, or me, I want to pull the human head backwards, and we all have
Yes.
clinical arguments to do so.
Yes,
The results
exactly.
the results are the same. The result is that they have less apprehension and less pain and less symptoms of instability when you consciously contract the rotator cuff, whether it's the
Yes.
front or the back.
You don't think it matters. So, but so for what I, if we take, I want to dig in there because these are the questions I want to understand. Maybe other clinicians do. I don't know. But when you talk about, I call it posterior cuff infraspinatus, say, pulling the humeral head backwards. I think about loading posterior cuff for posterior instability to stop it moving backwards. So if that is that your posterior cuff is pulling backwards, we know that in say in 4-point kneeling that your shoulder is maybe moving backwards, then the reverse of that is true.
Yes,
Is
yes.
that
And
it's load
that's
and
indeed,
direct and specific, maybe.
yeah, and that's a difference in opinion, I think.
Okay.
When when I look at muscles, and their function, they pull
Yes.
on bones. They never push. So if you would
Yes.
go into external rotation and you want to avoid anterior translation, you can never do that with your subscap because the subscap is not pulling in the right direction. It's the external rotators that pull in the right direction. But that's I think it's completely understandable that we have both difference in opinions on that for the
Mm,
very simple reason that there is no evidence. There is
yeah.
okay, there is evidence, but you will always find the evidence you want.
Yes, completely. I
I have
remember.
I can have 5 papers to prove that I'm right, and you will also have 5 papers to prove that you're right.
Yes. But what is the truth? I guess, like it doesn't matter so much that I'm right. It matters that my patients are, that we have the answer for people, you know?
No, that they are better. That's the most
Yeah,
important answer.
sure.
That it works in the patient. So I think actually when I looked at your workshop and I compared it
Yes.
with what I do, we do the same, but the philosophy is different.
Yes,
But
which is so interesting, isn't it?
yes, yes, it is. Yeah, it
Mm.
is.
I need to think more about the muscles pulling, doesn't it?
I
Because I
think
guess
that's
I had been thinking, so say we take this posterior instability, I had been thinking to create some hypertrophy to prevent, to create some kind of buffer, maybe.
yeah, but that's something else. So
Okay.
I think the first role of a muscle is to pull on the bone. The
Yes.
second role is to have some muscle belly to protect the joint that is underneath it. For instance, in
Yes.
collision sports, I think that the muscle belly of the deltoid is really important. In a tennis player, it's of course it's important to move, but it will never protect a shoulder. But in collision
Yes.
athletes, it does. And there, I think, is the difference in opinion. In collision sports, you need muscle
Mm.
belly to passively protect the joint. And then maybe also the subscap is important because it protects the joint against collision. So I think
Yeah.
there is a real difference between contact and collision sports on one side and then the typical
Yes.
throwing sports on the other side. Also in not in the really early treatment. I mean, in the first 2, 3 weeks, it will be the same. But once that you have more a functional stage of your treatment, it will be totally different. And I have to be honest, we don't have a lot of rugby players here in Belgium.
Yeah. And some like we don't have the same level of throat, and there's handball
Yeah.
is in New Zealand is not, you know, it is mean is not big. We see water polo players, but people play a lot of cricket over summer, but it's a different type of throwing. But that is sort of mostly our throwing environment, I would say. And so
Yes.
the place is different, and maybe that is where I think the regional differences influences our approach.
Yes.
Maybe that
Yes.
is the point, isn't it?
Yeah. So
And yeah.
when you look at the Berne consensus statement on return to play and prevention in shoulder
Yes.
pain, it was published in GSPT 2022. We also put some clinical pearls in there or consensus statements that were
Mm,
different from collision sports compared to throwing sports. Because
yes.
collision sports have the disadvantage of the collision, but
Yes.
the advantage that they don't go into this huge, huge external rotation. And
Yeah.
then in I think in throwing sports that are not at all in contact, like tennis, it doesn't matter whether you have this muscle belly
Oh,
protecting your shoulder. You need
yeah.
performance in the highest degrees of external rotation. So I
Yes.
think there is a difference in sports, and that makes also the
Yeah.
difference in research, because
Yeah.
your research was mainly in rugby players, right?
Sure.
Initially. Yeah. And so I could never do rugby research here in Belgium. We don't have that. So
Yeah.
we have volleyball players and tennis players and swimmers. So it's a different kind of sports, but also different kind of shoulders.
Yes. And so then for people to understand the different how the research applies and where it comes from and who the participants are is
Yes.
incredibly important, is what you're
Yes,
saying
indeed.
there.
I think you
Yeah.
always have to check whether the population that you want to treat, that you
Mm.
also read the papers on the population that you
Yeah.
want to treat, and
Yeah.
then categorize them into overhead athletes or athletes loaded their shoulder but below shoulder height, and then the ones that
Mm.
work with a reverse chain, like swimmers and gymnasts and rowers.
Yes. Okay. Can you explain then, because that brings me a question around whether your cuff works isometrically to stabilize or as a rotator? You know, do you think it's important that because lots of we tend to, loads of the patients that I see who have previously had physio here in New Zealand will be given TheraBand exercises to internally and externally rotate. But we know the cuff is, you could load it isometrically in loads of different ways. For me, if I'm wanting subscap, I know that if I put my hand behind and I load them, that I'll bring on some subscap. And the same thing when you're planted in a
Yeah.
plank, you will get more posterior cuff. Do you think then when should people isometrically load to stabilize versus rotate? Do you have any thoughts about that?
Well, I think that the cuff will never work isometrically in daily life because when we move, it works either
Yes.
concentrically or eccentrically. So by definition, it's impossible.
Yes.
I also think that the cuff as such, especially the subscapularis, it will mainly work when stability is challenged. So if you do these safe exercises here, internal external rotation, you
Yes.
don't challenge your cuff because you don't challenge stability. But if you put your shoulder like this, then the
Yeah.
cuff will say, "Oh, now I have to work." And that's one
Yeah.
of the things I think when you train an athlete, whether it's collision athlete or another one, you have to put them in positions that they will also be experiencing when they do their sports. So when you put the shoulder like this in
Mm.
handball, for instance, in a tackle, the shoulder has to react by saying, "Oh, I know this. I've been there before. So I've been there. I've been training there before." It should
Yeah.
never be in a condition during the sports I say, "Well, I was never here during rehab, so I don't know what
Yes.
to do now."
Yes. And so that was leading into another question, isn't it? Is around, do we then layer that up enough in the clinic to replicate those different activities? Is there advice you have clinician for the clinicians, the ones that I see who have internally, externally rotated their shoulders, how should they be layering that up?
I think that in general, and that's the response that I get from coaches, they say, "Well, when you say you are finished, we still have to start. So
Yeah.
our rehab is a bit too far from what the coaches need the shoulder to be able to perform. So I think
Mm,
talking to the coaches, communicating, working together in the final stage of the rehab is
yes.
really important. I was
Yeah.
involved for some years in the gymnastic world with mainly the
Mm.
boys between 12 and 18 years old. And very often the coach says, well, you have done nothing so far of what I need to do in the gym. So, and then it's about positions of arms that we think are really
Yes.
not normal anymore. So we need to communicate with the coaches of
Yes.
on the in between the final rehab and the optimal sports performance.
Mm.
Because I think in athletes we often don't load the shoulder enough
Yeah.
to challenge what they need to do in their sports.
In those specific positions, isn't
Yes.
it? Yeah, to
And
make.
that's why when you have an athlete that is here during the sports in a tackle, the
Mm.
shoulder needs to realize, oh, I've been there before. This is safe for me. But if you
Yes.
train it, it will never say, this is safe for me. So we should
Yeah.
do it sometimes more in a more functional way than we
Yeah.
usually do.
Yeah. And so that makes me think then, because I've looked at some of your work on perturbations, early stage, and for
Yeah.
me, and there's so for me, I would train the muscle isometrically, then load it up, and then progressively, then I add speed, and I'm really because when you publish papers, I'm like, oh, we're doing the same thing, but like you say, for different reasons. Been using the metronome to then try and speed up patients, and then I would add my perturbations,
Mm.
thinking, okay, now I have muscle strength and speed of movement. Now I can move to reaction time afterwards. But sometimes you would perturbate earlier.
Earlier,
At,
yes, but in a safer position. So I think that
yeah,
perturbations are possible if you keep the shoulder in a safe position. So the whole
yes,
procedure about motor control and endurance and strength and speed,
yes,
you can do that in many positions, but you don't have to wait, I think, until you are here to add perturbations. You can do that also in the more safer position, like in the neutral position, you can already
yes,
do that because then you add something to your treatment that is relevant anyway at the end, but you do it in a safer condition. So the muscles eh, that this is no science, this is more the clinic now.
yes. No, I'm
The
interested.
muscles get adapted to the fact that not everything is controlled. So not all
Yes,
the conditions are controlled.
yeah,
And that's actually after, for instance, a stabilization procedure, a banquet repair or Latarjet, I
yeah.
start these perturbations rather early, but in the neutral position,
Mm.
just to teach the muscles they need to be able to react and not only to produce force.
Yeah, because that is, and that's what made me think of that question, because then that's the responding to challenges of stability, eh? And so,
Yes. Yeah.
yeah, it's painful for people. I've never done that because I've always been thinking, endurance, then speed, then perturbations from a strength and conditioning component.
Yes.
It's
Yeah.
painful. Clinicians need to be careful, or
Well, to start with, it's not supposed to be painful. So if it's painful, it's too early. But
yes,
if you
okay.
keep the position of the shoulder safe, you can
Yes,
start rather early.
yes,
You don't have to wait until they have these positions in which they are also performing in their sports. But it's not supposed to be painful. They
no.
should feel safe.
Yeah, it's so interesting because you mentioned safe a couple of times now, and like similarly, I am really interested in the psychological impact of having these
Yes. Yeah.
dislocations, and Giesel and I have published some work that's looked at the enormous impact of this.
Yeah.
Do you have any comments around that? I feel like I'm starting to scratch the surface there, but
Yeah, well,
what do
the
you
thing is,
know?
I think psychological readiness
Mm,
is for rehab and return to sports. It's something that I was not educated with. We just looked at the shoulder, not at the
yes.
person where the shoulder is living in. So I really think it's important that we take that into account because when I look at these famous soccer players who fail to return to play, it's because they are afraid
Yeah.
to injure the same injury again. So I think that it's really important to do that. I also believe that the CIRSI, so the questionnaire on the instability and the psychological readiness, is really something that we should implement in our return to play
Mm,
procedure to see are they ready or not. In the clinic,
yes.
I don't use too much questionnaires in the clinic, but I asked them, are you afraid to be injured again? What is your feeling about going
Yeah.
back to sports? I had my own son who had a Latarjet injury. So
Okay.
actually, based on your studies, I asked him before he was operated, are you afraid to dislocate again? Because you have proven that is one of the risk factors,
Yeah.
fear of
Yeah.
re-injury. And he said yes. He played lacrosse, which is probably, is it popular in New Zealand, lacrosse? No, no. So, but it's rather, let's say that's also collision sports. And he says,
Yes.
well, I don't want, I'm afraid to play fully motivated because I'm
Yeah.
afraid to have the same injury again. So that was for me an argument to say, then you need surgery because you will
Yeah.
redislocate because of that. But also afterwards, I did not really put a questionnaire under his nose, but I really asked him, do you feel safe? Do you have any concerns if you would play sports again? And it's really something that we have to consider.
Yeah. So important, isn't it? And I think, and that sort of leads us into, well, how do you make people feel safe? And there's,
By bringing them in a position that the shoulder says, I've been here, this is safe for me.
yeah,
So
so they know.
yes, yes. So we have to really train them into
Yeah.
positions that are similar to the ones in the sports. Like for
Yeah.
instance, in lacrosse, it's then with the big stick, and so they need to train collision to be able to feel safe during collision.
Yeah. And that sort of leads into what we could be doing more in the
Yes,
clinic in that
and
space.
then they will feel better, and then the psychological readiness will be better.
Yes, because it's the experience of doing that,
Yes,
eh?
of course. Yeah.
It makes people feel differently. There's a couple of things before we move to talk about multi-directional instability, because I think we also have then some similarities and differences. I wanted to talk to you about co-contraction of the cuff. Because the little work that I wonder whether there is such a thing, the little EMG work that I've done with Tim would say that if you put people in these different positions, you will load the cuff differently. I think, does it then just respond to direction and load? But I can make my posterior cuff come on. I can make my anterior
Mm.
cuff come on. Do you think that co-contraction really is a thing? What do you?
There will always be co-contraction, but not in the same amount. So of course, if you have a condition in which you need your subscap to work, the
Yes.
infraspinatus will work too. But I think that
And
indeed that the which muscle is more activated will depend on what you do. So
yes.
there is a direction specific activation, but it will never be like that the other side relaxes. So it's not like you contract one side and you relax the other. There will always be a
Yes.
co-contraction, but the amount of contraction will be different depending on what the demands are. And that's also I mean the studies from amongst others Karen Jin. She also showed that there is direction specific activation.
Yes. Yes.
Also, there is a study where they performed some anterior translations on the human head,
Yes.
see what happens when you contract your posterior cuff. And
Mm-hmm.
they saw that if you contract your posterior cuff by asking an isometric external rotation, you control more anterior translations. So I think the anterior posterior translations of the human head are really controlled by a co-contraction, but the co-contraction does not mean by definition that they work equally. One works more, but they always work
Yes.
together.
But it's
The
not like they
stick,
have an agonist-antagonist relationship, hey? Their function is different.
they have to work together, otherwise you have
Yeah.
no stability. But
Yes.
depending on what you ask, what your demands are, it will be more
Yes.
subscap or more posterior cuff, I think.
Okay. And maybe that's the answer, isn't it? Depending on what the patient is doing. Which sort of leads us nicely from there then into multi-directional instability. I'm just doing yeah, it's what a fabulous way for me to start my day. I think our approaches differ here a
And
little
finish
bit.
mine.
Yeah, yeah. And so maybe sometimes to start, somebody with I've looked across the literature at multidirectional instability, and I'm talking specifically, I guess, about the patient with a predominantly posterior direction. They would elevate into flexion and maybe sublux posteriorly at 20 or 30 degrees for me. And then when I stabilize their humeral head, then that increases their elevation. They come with all those scapular components too, of course, but at a cuff level, then I think about, stabilizing their humeral head. So for those patients, I would put them inside lying with their hand in the ear, thinking that I am trying to put their humeral head on the glenoid. But for you, that's not where you would start, eh? This was the discussion we had.
Yes, yes, yes. Well, it's really interesting again that all roads leads to Rome.
Yeah.
What when you explain, I put them side lying with the hand with the arm abducted 90 degrees to have some stability covered by the rotator cuff. I would say you are training the deltoid and you give a
Yes.
compression into the glenohumeral joint. So the exercise is exactly the same, but we
Mm,
explain it with another mechanism. What I do
yeah.
indeed in multidirectional stability is maybe two things. I work three things. I focus on the deltoid because I really think that it has to pull the human head up. And
Okay.
multidirectional stability, they have either antero or postero inferior instability, but it's always inferior. So we need to pull the human head up, and the deltoid can do that. So that's
Yes.
one part. That's the difference probably, I think, between my approach as far, and it's not science-based, it's clinically based, and some others. So
Yes.
I focus on the deltoid. The second thing is I prefer close chain exercises in the beginning for the same
Mm,
reason. It gives approximation joints, not high load. I mean, you don't have to do push-ups, they cannot do that, but low load and moderate load 4-point kneeling exercises. And when I do open chain exercises, that brings me to your exercise. Then
mm-hmm.
I also provide some compression in the joints by gravity or the external resistance. So, for instance, if you would stand and perform an abduction 90 degrees, that would not be good because you train your deltoid, but the weight is pulling your human head down. So people
Yes.
don't like that. But when you do it side lying, like your
Yes.
example, then it's perfect. You train the deltoid and you
Yes.
have compression in the joints, so it's a safe condition. But once again, I think that there are many different approaches in multidirectional
Mm,
stability. I think if I compare what I do in the clinic, because I'm not the researcher on that level, and for instance, what Andrew Jaggi is doing in the UK,
yes.
and what Tanya Pizzari and Sarah Warby are doing in Australia, they are different, but
Yes.
they all have some gut feeling good ideas biomechanically. So
Yes.
and probably it doesn't matter too much what the background is as long as the patient feels safe during the exercises. So I might switch from closed to open chain because I
Yes.
feel the patient is not feeling well doing one of them.
Okay.
But
Yeah, based
main
on the.
focus to start with is indeed dealt with, and on that level, I'm
Mm.
totally different from many other people that
Yeah,
I
but
don't.
it's challenging, isn't it? Because for me, I was thinking, because I know from some of the work that I've seen is that when you go posterior again, you'll get anterior cuff and that so then I would start people in some circles, then weighted circles. But actually you're right. I'm
I would do
probably
this. I would do the same, but then I
yeah,
would do that to activate the deltoid,
yeah,
and we
yeah.
probably activate
Which
both.
yes, exactly. That's exactly what I was thinking. And so do you have any, when you put people to, so I had been progressively loading them here before I then tip them onto their side necessarily to then load in that position because of the body weight. Do you have any, I could just, some people I've really started in kneeling with just their hands, some nervous young girls who don't want to put any weight, they're sort of
No,
kneeling with their hand on the ground. Do you have
no.
any other tips for me or
Yeah, well,
about that?
I always start with what I call low load close chain, and low load in this context means no body weight on the shoulders. So
Yeah.
whatever you do with a ball on the bench or on the wall, so or against the wall, that they don't need to put some body weight on their shoulders because they are very often afraid to do that. And I
Yes.
think in these patients, we all see these young girls in front of us that we need to get the trust from the confidence of the shoulder, the confidence
Yes.
of the girl, most of the time also the confidence of the mother of the girl, is very often dominantly present, but you need confidence. And the only
Yes.
way to do that is to make sure that they don't sublux when they do exercises. So
Yeah.
it's sometimes to under dose your exercises and say, I'm going to make it a bit easier to make sure that they don't feel unsafe and uncomfortable. So I will
Mm.
never go to the 4-point kneeling position before I do some exercises in a closed chain where they don't load their body weight on their shoulders. And also, for instance, when you go from no loads to moderate loads, I I very often start with them. They are sitting on their heels and
Yes.
with their hands on the slide support like 20 centimeters, and they have to load it and come back and
Yes.
load it and come back, really get used to some loading in closed chain. And once that
Yes.
they are loaded, then they can do, for instance, extend one leg to make it a bit more challenging. But I think
Yes.
it's really important for them to feel safe.
Yes, and maybe I'm jumping a few steps here, which is why I'd gone that way. But
Well,
I
that's
could,
also that's it's also very safe. So in an open
mm,
chain exercise, the most important
yes,
thing is that if you use gravity or um, a dumbbell, that it
yes,
provides some compression in the joint.
yes. And so the similarities here that I'm hearing, and I guess what I'm taking from this is that where I had gone into that position for a safe open chain, you might have done some safer closed chain things here before you went to resting on your heels.
Well, both of them. It depends on the patients.
Yeah.
Sometimes, for instance, now if I can switch briefly to the EDS patients,
Yes.
in Ehlers-Danlos, the connective tissue disease, they are so fragile that
Mm,
they cannot cope with closed chain exercises. So there you have to do open chain exercises like you suggest, because
yeah.
they cannot even push their hand into a ball. So it depends a little bit on the patient. Sometimes they feel safer in a closed chain, then we go for closed chain exercises. Sometimes it's too much, then we go for open chain, but with compression in the joint.
Yeah. Okay. I'm going to ponder on this now for the rest of the day. So thank you. Thank you very much. We've talked for way longer than I thought we were
It's
going to.
fine.
So my apologies for taking your time. Do you have any other final comments you wanted to make about shoulder instability, micro instability? Are we even calling it the right thing? What do you
Yeah.
have any final comments for clinicians?
I think for the clinician, it's important to identify the kind of instability. The traumatic one is easy because they had a
Mm,
dislocation. The
yeah.
multidirectional, most of the time, they don't really are into sports because they are too weak to do sports. And then in the middle, we have the ones who have some sports-related micro instability. But for me, the approach is different depending on the kind of instability. And sometimes when you make a wrong diagnosis on that level, you
Mm,
might have the result that the patients are not feeling happy with their exercises. So finding out what kind of instability it is important. And that is something that I, as a young clinician, I didn't do that. It was instability, endpoint. And now
yeah.
we have the traumatic ones are the easiest ones, not to prevent re-injury, but to,
Yes.
to do
To
rehab.
diagnose. Yes.
Yes, and the ones with MDI, multidirectional stability, they are the most complex patients that one can have, I think,
Yes.
given the fact that there is a lot of psycho-emotional background also on that instability. And then in
Mm,
sports, you have more anterior or posterior, depending on what kind of sports. And there we
yes.
have to work up to the loading of the cuff again. But the initial diagnosis is important, that we know what kind of instability do we have here.
Yes. And when you say what kind, you're meaning, is it traumatic? Is it
Yes.
multi-direct? Do you think about the direction of that? Is that what you mean? What
Also,
kind?
also, what the kind for me is traumatic, that's one.
Yes.
Sports related, that's two. And then
Okay.
atraumatic based on laxity, that's three.
Okay.
And I know we have other kind of classification systems,
Yes. Yes.
uh, and mainly in the third group, the atraumatic ones, we have the ones that are based more on muscle recruitment problems rather than structural problems, but
Hmm.
they still remain multidirectional. So for me, it's traumatic, sports related, or
Okay.
non-traumatic.
And then really identifying that, because I guess what I
Yes.
see in the clinic is clinicians missing the instability component when they present with cuff-related pain. But
Ah,
the
yes,
reason
yes,
they
yes.
do that is because of their
But then
instability.
they will probably be in the second group, the sports related group,
Yes.
because they
Yes.
have a lot of cuff related shoulder pain. They present with pain, not with instability. They don't say, I have shoulder instability. They say, I have shoulder pain. And
Yes.
we have to identify whether the pain comes from a
The,
subtle micro instability. And the other
mm,
ones is easier. I mean, you have a dislocation or not. And in the multi-direction instability, very often the laxity tests are positive. So you know already when you
okay.
bring the puzzle together, the laxity test together with some psycho-emotional problems, maybe some voluntary subluxations. So it's
Mm,
another picture.
yeah. Hey, I don't want to keep you any longer, but thank you. Thank you so much, Anne. It's been truly wonderful for me
Yeah,
to,
it was really fun for me too.
yeah, I've really enjoyed it. So I really appreciate your time. Thank you.
And I hope that the listeners also like it a little bit and that they can apply it in the practice.
Yes, that would be neat. Thanks. Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. Don't forget you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.